All right. Hey everybody, my name is Jeremy Walker. I do transplant infectious diseases at UAB. I'm here to talk to you about respiratory viral infections. It's actually similar to a talk I did about a year ago with just a couple of updates, given some things going on. I don't have any relevant financial disclosures for this talk. I do have a couple of clinical disclosures I always like to give. One is I take care of patients with immune compromising conditions. I think a lot of times people see that as niche, but it's actually not so niche these days. About 6% of the US population is on an immunosuppressive medication, at least at some point over the course of the year. Has doubled over the last decade. It's only going to keep rising. So I think we need to be more and more aware of some of the patients that may be more vulnerable, especially for infections like this, common viruses that can be more severe. I also could talk a lot more about any one of these viruses. I'm going to try to give you an overview. And finally, I do use a little bit of open evidence, mainly to find resources. If you haven't used that yet, I would highly recommend it. It is an AI tool put out by several universities, essentially that allows you to Google search PubMed. So it only pulls from PubMed and will help you to find really good review articles, etc. It is free for anyone with a MPI number. So with that, learning objectives, we're going to talk about clinical features of common respiratory viruses. We're going to identify patients at highest risk. We're going to review some management options, and then we're going to talk about how we can prevent respiratory viral infections. So of course, influenza, SARS-CoV-2, adenovirus, RSV, those are probably the biggest, most likely to cause severe infections, although there's many more common viruses that we see in our community. And so that's what we'll kind of get through first. We're going to talk about the level of infection and kind of some of the syndromes that we see, and then we'll jump into management. So thinking about level of infection, generally we define upper respiratory tract as sinuses through larynx. Viruses more commonly infect the upper respiratory tract, although certainly you can see bacteria there as well. Lower respiratory tract, really getting in the trachea, bronchi, alveoli. Especially when you get to the alveolar level, you think more about bacterial pathogens, but certainly both viruses and bacteria can be problematic at every level of the respiratory tree. But we'll kind of talk a little bit about both upper respiratory tract infections and lower respiratory tract infections today. So first case, just to get us thinking, so you have a 35-year-old presents to clinic with concerns of a dry cough for a week. Symptoms were kind of gradual, has a sore throat, some nasal congestion, some body aches, mild headache, no fevers or chills. Sore throat is more prominent in the morning, common with postnasal drip, and concerns about this ongoing cough has prompted him to come in for some antibiotics to, quote, knock it out. The first question is, how would you label that infection, right? Because that's the hard part, like labeling it will help you define how you might want to treat it. So you have some options there. And so if we go to a nice kind of review article in the AAFP, which I pull some from, it kind of outlines some of the different symptoms that are common in all of these kind of upper respiratory tract infection presentations. And one of the challenging things is a lot of these symptoms do overlap in a lot of different ways. I would argue for our patient, that we just described as probably more of a common cold because it really didn't localize to any part of the respiratory tree, had a little bit of a sore throat, a little bit of a headache, but also kind of a dry cough. There wasn't like prominent symptoms of pharyngitis or bronchitis, etc., being kind of the primary syndrome. So I would have labeled that as common cold, but as you can see, there's a lot of variation there. And I think, you know, good physicians can look at the same patient and probably come up with slightly different terms, but they're very similar because a lot of these viruses actually can cause infections at all these different layers of the respiratory tract. So sinusitis, to begin, kind of starting from the top, very common, as you probably know, right? Over 30 million adults in the US are impacted, have visits for this. Inflammation of sinuses is really common in any viral respiratory tract infection, and there's no way with imaging or other things to clearly differentiate bacterial versus virus. So most will have imaging changes transiently, and sometimes we'll get called for that when a CT is called, obtained for other reasons. Generally, we expect sinusitis to be fairly self-limited over the course of a couple weeks, and rhinovirus, influenza, paraflu, those are kind of our common viruses. Very few of these are, the leading theory is that they progress to bacterial sinusitis. They generally start as a virus, but then are kind of super infected. It's less than 2%. The primary pathogens are strep pneumo, H. flu, Moraxella. Things that might make you think of a bacterial infection, symptoms that are prolonged over 10 days, fever, particularly with purulent discharge, facial pain that is persisting for several days. So, obviously a lot of these viruses may have a brief fever, but usually they're not going to persist, and particularly persist with those focal findings of the discharge and facial pain, or worsening symptoms. So again, this could be a super infection. So if you were almost better and then all of a sudden 5, 6, 7 days in start having fever and more of these localizing symptoms, those would all be suggestive of a bacterial infection. If you do have concerns for bacterial infection based off those pathogens, amoxicillin clavulanic acid or Augmentin is generally a preferred therapy. Doxycycline or fluoroquinolone can be considered if there is a true penicillin allergy. But ideally, very few of those cases require treatment because it's really less than 2%. For pharyngitis, again, pretty common, 12 million adult office visits. Generally, this is a sore throat, manifesting as a sore throat. One of the hard things is that if you look back in that prior table, a lot of these infections will have a sore throat along with other things. And you see basically any virus that you can think of on a viral respiratory tract panel can have symptoms of sore throat, in part because a lot of times when you have a lot of upper respiratory congestion, it'll kind of go down the throat and cause irritation. Only about 5 to 15% of people who present with what's labeled as pharyngitis is actually from a bacterial cause. Mainly that's group A strep and Fusobacterium. You may remember Centaur's criteria. It's one of the kind of things that might suggest a bacterial infection. It's all things that are a little bit intuitive. If you have a local exudate, if you have local tender lymph nodes, presence of a fever, and then also absence cough. So kind of the cough would suggest more of a viral prodrome. So those are all things that may suggest bacterial cause. If you do have a bacterial cause, amoxicillin is preferred for both group A strep and Fusobacterium. It will give you good coverage. Note that people used to use more macrolides, but that is actually not very reliable, especially for Fusobacterium, which we see more and more commonly in young adults. And so would really encourage clindamycin if you have amoxicillin allergy as your treatment of choice in those cases where you think it's necessary to treat, which should be fairly rare when they don't have the viral syndrome alongside it. Laryngitis, a little bit lower down, actually a much less common presentation. It's common to have some symptoms of laryngitis. It's just most people don't go to the doctor specifically for that. It may be one of many symptoms that they have. Generally, this is related to viral infections. Again, many of the common viruses that we see in the community can cause it: influenza, paraflu, RSV, etc. The one kind of unique one here is herpes simplex virus, sometimes can cause laryngitis. Very few cases are related to bacteria, usually kind of some of the atypical ones like Moraxella or H. flu. And regardless, actually, empiric antibiotics have not been found to be beneficial in any group of patients with just presenting with laryngitis. So antibiotics are generally not considered here. Obviously, if you had particularly severe symptoms, high fevers, trouble swallowing, purulent secretions, that's going to prompt you to be more concerned, mainly because you're thinking about pharyngitis, which we're going to talk about in a minute. That does warrant treatment. And if you were trying to cover those pathogens, again, Augmentin would work well, kind of similar to our sinusitis. But strictly speaking, you really shouldn't be giving antibiotics for laryngitis as a primary presentation. Epiglottitis. Much less common. Notice that this is ED visits because this is an emergency and not something that generally is going to be managed as an outpatient. The two kind of syndromes you might think about is either someone coming in with progressive, fairly severe, fairly acute dysphagia, drooling. The other presentation would be really like rapid onset, fever, stridor, respiratory distress. Both of those things obviously would be quite concerning to any physician that's evaluating the patient. Over 90% of epiglottitis is from a bacterial cause, so this is why we need to make sure we treat these aggressively. Generally, strep pneumo and Staph aureus is the pathogens we think about. And empiric antibiotics may include like a third-generation cephalosporin or an anti-staphylococcal antibiotic like vancomycin. Honestly, you would use those two in combination because you'd want to make sure you get the best coverage for Staph aureus and strep pneumo. And we have a lot of methicillin-resistant Staph aureus in our community. Moving on down the respiratory tract now, getting into the bronchioles. Bronchitis is, again, pretty common. Over 10 million visits. These are kind of outpatient visits. Generally, bronchitis is defined kind of by longevity. So this is when you have that ongoing cough after a respiratory illness for several weeks, really up to 6 weeks. Sometimes there's kind of some persistence of there's mild symptoms of a little bit fatigue, a little bit of sore throat, etc. Many of our common viruses, again, do this: rhinovirus, coronavirus, RSV, flu, etc. Very rarely is this related to a bacterial cause. Again, mycoplasma, the atypical, so mycoplasma, chlamydophila are the two that can do it. But again, kind of like laryngitis, empiric antibiotics have not really been found to have any role in this group. Of course, if you're thinking about pneumonia, that's a different story, much like we talked about before. But if you're looking at a true bronchitis, just this mild persistent cough, there's really no role for antibiotics, and there may be harm, of course, with antibiotic overuse, things like C. diff, etc. Pneumonia, lowest part of our respiratory tract, getting into the alveoli. Again, this is more of an emergency generally. I mean, sometimes it can be managed in the outpatient setting, but if you look, it's about 700,000 ED visits. You expect, of course, high heart rate, fast respiratory rate, fever, and then really it's defined by kind of those focal findings on exam or chest x-ray. Again, viruses can do this. We particularly think about influenza and SARS-CoV-2, but RSV, metapneumovirus, adenovirus, many others can, and particularly in our immune-compromised patients, we see that more frequently. But we have to assume and have to worry that there's a bacterial cause. And so, of course, strep pneumo is one of our more common, H. flu, Moraxella, mycoplasma. These are all common causes of community-acquired pneumonia. Legionella, we worry about more in certain scenarios. In the southeast, honestly, we see it more in the summer because it's associated with water sources and air conditioning units. The big point is you may change, of course, what you're worried about if it's hospital onset versus community onset, etc. And so your empiric antibiotics may change a bit, but you're going to worry about bacterial pathogens and generally treat for bacterial pathogens when you have pneumonia until you have a more clear picture of what's going on, and what you choose is going to be based off if it's community acquired versus hospital onset. In the community, you're going to cover for strep pneumo, you're going to cover for atypical pathogens in general. So let's move on to case 2. So we have a healthy 45-year-old presents with concerns for ongoing cough for a couple weeks. Symptoms came on gradually, sore throat, some body aches, etc. But now only a lingering cough productive of some yellow sputum. So what is the best next step in management? So this is supposed to be kind of describing more of that kind of chronic bronchitis kind of picture, in which case we would really be thinking about symptom-focused therapy rather than antibiotics. So just a reminder of what we discussed: laryngitis, bronchitis, really not a role for antibiotics routinely in those populations. Pharyngitis, sinusitis, there is a role kind of in a defined subset. For sinusitis, it's those patients who seem to have progressed to bacteria, usually because of worsening of symptoms during the course of the illness. For pharyngitis, it's usually kind of with onset you're concerned about bacterial causes, primarily defined by the appearance. There's more purulence, there's more tonsillar exudate, and the absence of other viral symptoms at the same time. So that group would those portions of those presentations would warrant antibiotics. And then epiglottitis, pneumonia, those are our more severe presentations. Those are the ones we more think of in the ED, et cetera. And generally, we provide empiric antibiotics for those, especially until we've got a better understanding of what's going on. Sometimes if you do diagnose influenza or you do diagnose SARS-CoV-2, you may be able to tailor down those antibiotics, but it's at least empirically you're going to start them. So we'll come back to what symptom-focused management looks like. Let's first, before we go to that, we've kind of defined it by area in the respiratory tract that we have, and we've seen that there's a lot of viruses that could cause this. I think it's worth taking a minute to talk about some of our viruses in particular that are more notorious for causing severe infections. So to begin, we have a healthy teacher, comes in with fever, body aches over the last day, non-productive cough. Several students have been sick. What is the most likely cause? You see some options here, and I would argue that really this sounds most like, at least the severity of symptoms, a flu-like illness. So you'd think about influenza, but it could also be SARS-CoV-2. And so how would you differentiate the two? And in this case, there's no clear, easy way, but one thing I like to point out, if you're not aware of it, probably not. It's not necessarily the best, I guess, conversation over the water cooler, but there is actually wastewater testing that's done. There's 3 sites in the Jefferson County area, and that's one of the best ways to know what respiratory pathogens are kind of spreading through the community at any given time. And so you can just go to that website, you can go look there, it'll tell you SARS-CoV-2, influenza, RSV, norovirus, all of those kind of trends are labeled there, and it's just looking at how much of it's in the wastewater. So it's a really good representation of what the community looks like. So if you look and you see there's a ton of SARS-CoV-2, it's probably SARS-CoV-2. If it's a ton of influenza, you would think probably influenza. Of course, you could do some additional testing, but that can just give you a sense. If you're stuck making an empiric kind of decision or consideration, it will at least help a bit. The way that it was described, abrupt fever, myalgias, all kind of together, is a little bit more influenza. SARS-CoV-2 tends to have more of a prodrome of upper respiratory stuff before it builds. So if you were writing a board question, that was written to be more of an influenza question. And so that's what you should think about. GI symptoms are common in kids. In fact, sometimes all you see with kids, but less common in adults. So that it is certainly the most common cause of viral pneumonia prior to SARS-CoV-2. At certain times we see more of it. I know this past a couple months ago we saw a lot of admissions for influenza, including some with pneumonia. It can lead to ARDS. Particularly H1N1, which tends to be a more immunogenic variant. Of risk factors for severe disease, pregnancy is a big one that comes up and important to recognize. Age, particularly those over 65 and patients in nursing homes. Other things, anyone who's immune compromised, which is really kind of a blanket term for anyone on an immune compromising med or with other cause of like myelodysplastic syndrome or something else that would lead to a chronic immune compromised state. And then people with lung disease, COPD, asthma, etc., and which all kind of makes sense. How do you diagnose? Well, you could do rapid assays. The preferred is a rapid nucleic acid test because it's more sensitive and specific. That's looking for nucleic acid of the virus. You can also do an antigen-based test that's protein-based. In general, when you go to antigen, you lose some sensitivity, so that you drop the sensitivity down a good bit, but you do raise the specificity, or the specificity is pretty much equal to the molecular assays in the case of influenza. So part of it's just availability. The nucleic acid test tends to be a little bit more expensive. Some places have the antigen-based test. But as you can see with a sensitivity of 50%, if you had influenza spreading in the community and someone presented with a classic syndrome of influenza, you wouldn't want to necessarily believe a test with 50% sensitivity to rule out infection, right? And so that's where, which test you have is really important to recognize, so you can decide, are you going to ignore a negative in the case of community spread and empirically treat the patient as if they have pneumonia. I'm sorry, as if they have influenza. Antiviral treatment generally is provided when patients are hospitalized, kind of regardless, not that there's been clear evidence that it necessarily has that significant of benefit. It's just that we worry that patients that are high risk for influenza complications, if we don't arrest that viral replication, it may be prolonged and cause additional damage. In the outpatient setting, generally, it's best if done within 48 hours of symptom onset, and it's kind of a little bit of a risk, or really, the drugs are fairly well tolerated. It tends to be more of a discussion of kind of the cost of the medication, et cetera, when deciding whether or not to use it. Sometimes oseltamivir can cause some GI symptoms. Oseltamivir is kind of the standard with which probably most of you have used. It's been around the longest, so it's the cheapest of this list, although it's not necessarily cheap for all of our patients, certainly. Baloxavir is a newer drug. It has a unique mechanism of action. It really doesn't have a ton of data in some of our sickest patients, like immune compromise or pregnancy, but it is an option, just slightly more expensive. Zanimivir is an inhaled option, so you shouldn't use it in patients with obstructive lung disease. And Peramivir is an IV option, really only used in those who cannot tolerate oral agents. Ultimately, cost and lack of additional significant benefit leads to oseltamivir being the most commonly used one. SARS-CoV-2, I think something that people who have been in healthcare for the last 5-10 years have come very familiar with, and certainly have kind of seen this evolve over time. Of course, it still kind of can be anything from asymptomatic to severe respiratory distress and pneumonia. As I said, upper respiratory symptoms tend to precede fever, myalgias, and lower respiratory tract stuff. Fever and hypoxia suggest more of an inflammation, is what that should say, and more of a severe syndrome. We definitely have seen a decrease in the severity over time. It's hard to know how much of that is based off changes in the new variants versus how much of that is just that we as people have become exposed, and therefore our immune system has had some opportunity to build a response, whether that be through vaccination or through exposure to the virus. It's really hard to find someone who has never had one or the other at some point over the last 5 years. Risk factors for severe disease, though, remain unvaccinated status, older age, certain metabolic syndrome, hypertension, diabetes were kind of more predominant, especially early on. We still see severe disease sometimes in some of our immune-compromised patients, severely immune-compromised, patients with solid organ transplant, stem cell transplant, et cetera, as would be expected, sometimes, especially if they're at a time where their immune system has had a particular large insult, like immediately after induction for some of these procedures and therapies, you're at a little bit higher risk of having severe disease. How we diagnose SARS-CoV-2, again, something many of you are, I'm sure, familiar with. There are two standards, much like influenza. You have the nucleic acid test. It's definitely the most sensitive. The problem with that is that it has to be done in a lab, and so there isn't really a lot of at-home, easily accessible, in real-time testing for nucleic acid. B, it can be present for a long time, and so especially when people were using a test-out model, which is not very common anymore, but it could have been sent for just testing out or for pre-procedure stuff, and we'd see it positive, and it could remain positive for up to a few months, actually. So not the best test for those purposes. The antigen-based test is nice. Protein-based, again, of course. It's quick, cost-effective. It's the one that you all had in your homes and used when you needed. There is some risk of false negative early in disease course, but there's the benefit of it does kind of, as your viral titers go down, it more quickly dissipates, so a lot better for testing to rule out, et cetera. We still occasionally have to do that for our severely immune compromised who are trying to get to procedures or to certain therapies and things, and we want to give them some time to clear the viral infection. Treatment, hasn't really changed much. nirmatrelvir, ritonavir, or Paxlovid is generally an outpatient oral option that tends to have the best data, although it's still pretty limited. It does cause like a metallic taste. The biggest thing is some drug-drug interactions, which I'll show you in a second. You definitely need to be aware of those. Remdesivir is still our inpatient option. IV, the early data did not show a whole lot of benefit when patients were presenting with severe disease. There was some data in the Pine Tree trial that showed it might be more beneficial early onset for severely immune-compromised patients who are at risk of progression to severe disease, and so it may have more of a role there. Molnupiravir is an alternative. The data is pretty conflicting as to whether it has much benefit. We generally don't use it very much, but is an option. This is just a reminder, if you are going to prescribe Paxlovid, Liverpool Interaction Checker did put their data together to help with that. Ritonavir is a boosting agent in that. It's a boosting agent in HIV drugs as well. These protease inhibitors has a lot of interactions with the CYP system. So, this can be a good resource to go in and check and see if the patient has any conflicting medications. We see it a lot. Tacrolimus is what I put there. That's an agent that we use a lot for solid organ transplant. And we had a lot of patients who accidentally had this prescribed, by an outpatient provider, not realizing that interaction. So making sure you've checked some of those drugs in this interaction checker can be important, especially if they're on medications you're not as familiar with. On SARS-CoV-2, another one I've mentioned, especially since the vaccine is more recently out and people are asking about it, is RSV. Usually RSV causes nasal congestion, a sore throat. It's a very common upper respiratory tract infection. It can progress to pneumonia mainly in those who have significant risk factors, those risk factors being severely immune compromised, end-stage organ disease, or older age. And so the testing generally is RT-PCR mainly through a viral respiratory panel. Although you could, I guess, technically send an RSV-specific testing. There is no antigen testing that's sensitive enough to be used regularly, so there's not really point-of-care options generally available, at least in most outpatient clinics. Really, supportive care is the mainstay of treatment for RSV once it's diagnosed. There are some specifically, really lung transplant and recent stem cell transplant where we'll try things including ribavirin. Really should be done with a specialist. There's actually not much data to support it. It's just mainly that those patients can get very sick very quickly with a virus that you have no real good options for, and so sometime with risk-benefit consideration we'll elect to use like the oral form of that drug. But ultimately it's a pretty rare occurrence. So let's go back, or let's go to a new patient. So you have a 65-year-old female coming to clinic with fever, cough, myalgias for a couple days. Several family members are also sick with the same symptoms. Influenza has been spreading in the community. The patient is mildly tachycardic, otherwise stable, no signs of pneumonia. What is the best next step in management? You see some options there. I kind of told you that influenza was going on in the community, so would point you more towards influenza. So I would think about those options. Here, in this case, the nucleic acid test is not something they could do in-house. They'd have to send it to a local hospital. You wouldn't want to rely on antigen testing, which has a 50% sensitivity. So in this case, if you have it spreading in the community, you have a high-risk patient, it would be reasonable to go ahead and provide oseltamivir so you could get them started on therapy early, hopefully have the maximum impact. Now we're going to return to that case put forward a little bit before, where you have our female who presented with kind of ongoing cough for a couple weeks. She's got a sore throat, mild body aches, but really at this point just that lingering cough, kind of described like bronchitis. And we said there's not really any role for antibiotics here. Symptom-focused therapy is the best. So as we move into management, I think more broadly to these different syndromes, an important question comes up is, well, what is symptom-focused therapy? There's a lot of things, obviously, that you can use. A lot of things patients will get over the counter and elect to use. There's limited data for much of it. That AAFP kind of article from 2019 did a nice review of all these treatment options. And if you look at least the data that's put out for sinus congestion, your alpha-1 agonist there does have some benefit. For cough, inhaled ipratropium actually tends to have the most benefit. And of course, for headache, joint pains, your NSAIDs, ibuprofen more so than acetaminophen have some benefit. If you start very early, some of the zinc acetate, gluconate, Lesage, et cetera, actually have a little bit of benefit in decreasing symptom duration. And those kind of combination medicines of antihistamines plus an oral decongestant plus analgesic, kind of like what often you see in things like Dayquil, et cetera, again, may have some limited benefit in symptom severity. All of this is just helping with symptoms and generally not changing the duration of illness much. Things that have not had any clear evidence of benefit, all listed here, including many of the things that are still available and patients use all the time. A big one that has to be prescribed that I think, again, to emphasize is antibiotics are not going to help for these common cold symptoms, which I think is always hard because oftentimes patients are coming kind of hoping that antibiotic will be the magic ticket to get them better so that they can get on to work or get on to other things they need. I think it's important to manage these conversations, explain why they will not help, suggest I think it's helpful to kind of know what treatments do have some evidence that they actually help benefit, because that at least will help you to tailor their thinking towards those based off what their symptom is. Is it more congestion? Is it more cough, et cetera? And then manage expectations. Especially I think bronchitis is probably the hardest one because it does linger for up to 6 weeks. And so, it definitely can get frustrating over time. I have 3 kids under 6, and so I get plenty of these respiratory viruses and can tell you that sometimes it can be really frustrating to have that lingering cough. But ultimately, antibiotics aren't going to change that duration and just may cause problems with side effects. All right, so let's move on to a little bit of prevention. And so we have a 55-year-old with well-controlled diabetes, metformin, comes in for an annual exam. Let's say we're back in the fall. It's a lot of times when we're thinking about this. Done well since last visit 1 year ago. Was up to date with vaccinations before. Which of the following is appropriate at that time? You could think about multiple. You see influenza, SARS-CoV-2, RSV, adeno, and MMR. We're going to review kind of influenza, SARS-CoV-2, RSV, and the indications for those. Adenovirus generally is not routinely recommended in the general population. It will sometimes be used with military recruits and other groups that are living with many people in a kind of confined area. And then MMR is part of routine vaccination in childhood. We're going to talk a little bit about that as well because that's been something that's come up a lot in the news recently. Influenza, we'll start there. So this would be recommended for our patient. It's recommended annually in all adults. Generally, the new vaccine is released around September time. Most people will receive an IM quadrivalent vaccine. You can get FluMist. I'll tell you, my 4-year-old was all about FluMist. They learned at their daycare that there was a shot for the flu that wasn't a shot, and it was going around the 4-year-olds, which was just kind of funny. I'll acknowledge, of course, it is a live attenuated vaccine, so if you have a patient who's immune compromised for some reason, like the patients I care for, we generally recommend actually the high-dose quadrivalent vaccine to really boost or optimize their ability to respond, but not have that risk of a live attenuated vaccine that could cause the disease. Pregnant patients should receive vaccination. Remember, they're at high risk for influenza. That's an important point, even one that comes up on board exams and things, because you can have really severe disease and people don't want that to be missed. Older adults, again, should get that higher dose. We talked about that. Egg allergy is something that patients will sometimes ask about. It's no longer a contraindication to vaccination, not something that needs to be worried about. And another question that sometimes comes up, if you're going to get the COVID vaccine, can you do the two together? And you can. There's no reason to separate them. Speaking about the COVID vaccine, a booster was recommended in 2024. I haven't seen official word about for next year. I imagine that it's kind of seemed like it's going to be just kind of an annual booster is going to be the recommendation, but we'll see. These are the options. I know this comes up a lot because there's been some concern around mRNA vaccines by some patients, and so just Novavax is a protein adjuvant vaccine. So if patients are open to the vaccine but just do not want the mRNA vaccine, that is an option for you. Again, pregnant patients are approved for the vaccine, are at higher risk. We saw more of that with earlier SARS-CoV-2, but it's still recommended. Adults, that there is like kind of a lot of variation in what you give based off whether or not they've been vaccinated before and other things. And so you can kind of, it's probably worth actually just going to the website if someone is interested in vaccination and they haven't been vaccinated before or they weren't sure of their vaccine status. It'll kind of walk you through, the CDC website will, whether to do 1 or 2 doses. It can be co-administered as again with the influenza vaccine as we discussed. The newest one is RSV. So it was initially for those over 75. It's now been kind of lowered to 60 with risk factors. And you can see again, you have a couple of options. There are main ones that people are getting as antigen-based vaccines. There is an mRNA vaccine as well. It also is, I think, really the biggest group that it's been recommended in, or that a lot of people are aware of it in, is pregnancy. The reason is in part for protection of the mother, but honestly even more so protection of the child. RSV is a really severe pathogen in the first year to 2 years of life, and especially in that first year when they're most vulnerable before they're fully able to depend on their own immune system. The mother's immunity passed through breast milk will help the fetus or the baby. So at that point, it's been really kind of, I think, been integrated into prenatal care, but you also, a lot of our patients that are older, especially with immune compromised status, et cetera, have been asking us about it, and we've been providing it. Again, can be co-administered with influenza. Not currently fully approved for any high-risk patient of any age. It's mainly focused in on those 60 with risk factors, mainly just because we don't have a lot of data there. And honestly, it's a less common to cause severe illness in that population, again, outside of those very niche groups that are highly immune compromised. So this is kind of a case for recent times. So you have a 30-year-old healthy male comes in with fever, cough, runny nose for a few days, traveled last week to a resort in West Texas for vacation, grew up in a religious community, did not participate in vaccination, and you see this rash. So what you see is a diffuse maculopapular rash, kind of preceded by fever, cough, runny nose, or coryza. This is concerning for measles. Generally with measles, you'll have some initial upper respiratory symptoms at about day 10 or so. The rash usually shows up at about day 12 to 14. You're presumed infectious for about the 4 days preceding to the 4 days after that rash initially shows. So this is something that we're seeing a little bit more now. So measles is highly contagious. One person generally in an unvaccinated population will infect anywhere from 8 to 12 people. And so you really have to have a high rate of herd immunity to maintain it at bay. As we've had some decrease in that, we see some outbreaks, particularly in communities that do not vaccinate as a group, and so there's more risk for spread. So the current outbreak in West Texas is the largest in recent history. The disease can be severe in adults, and young children is kind of the highest risk 2 groups. One thing that's coming up more and more now is people will get their titers checked for various reasons. We sometimes will check them before people are, they're getting worked up to undergo a solid organ transplant. Some like healthcare facilities will check them and their employees before work, et cetera. So if you get them checked and they're negative, sometimes the measles or even the rubella will be negative, even though you had the appropriate vaccination. Generally, the recommendation is to just give one more dose of the vaccine to help boost those levels. There is it is likely that you would still have a pretty strong immune response, but having that extra dose, especially in current environment where there's a real chance that what we've seen in Texas could very much happen in Alabama, or some of those cases could come over. I think it's important that we are protected, especially for those who are going to be in healthcare and particularly taking care of those patients. One thing to know is MMR is a live vaccine, so measles, mumps, rubella, live attenuated. So that means that you cannot use it in your immune compromised. That's one of the reasons we like to try to check it before, like if we know someone's going to undergo a transplant or something else, so that you can then treat them or get them vaccinated before they would then go on to those immune compromising states. You wouldn't want to, if someone is diagnosed with like a malignancy or something else and you know is about to be immune suppressed, you wouldn't even vaccinate them then. You really have to have a window of about 6 to 8 weeks where you can safely vaccinate them before they're going to undergo treatment. So that's something that generally you can refer or ask like your ID colleagues, and they can help support you through. Varicella is another less common infection for us to see now. It's at this point mostly vaccine preventable, although many people had it just through natural infection, myself included, as we were growing up. It is more severe in adults when you see it. We will occasionally get a case, especially in people who have traveled. And so it's important to recognize that rash just because it's less commonly seen. And so the last couple of cases that I've actually seen it was missed because people were just not as familiar with it. Whereas probably 20, 30 years ago, no one would have missed the varicella rash because it's so classic. And it's really kind of defined by, and I wish I should add a picture here, but it's defined by having those lesions in multiple stages of healing. So just in case does end up coming through and end up you're admitting someone and you're a little concerned they could have measles, it's worth acknowledging what are the isolation precautions, how should we protect our other patients and our healthcare staff if a person comes in with suspected measles. Remember, droplet precautions are generally recommended for things like influenza. It's kind of for things that mainly live in the upper airways, which are large droplets. The idea is that if you're 6 feet away, it's very unlikely that those droplets will come into contact with mucous membranes. It also tends to be the things that are a little bit less contagious, like one person will infect 1 to 2 people because it does require that higher contact or closer contact. Airborne pathogens are in smaller respiratory droplets. That's at least the traditional view. They kind of float in the air. They can hang for a long time. If you've been in a space for an hour or so, you kind of fill the space with these small droplets, and other people that come into that space, even in the next hour or two, could still be exposed to them. Tuberculosis is probably the most classic example of that. SARS-CoV-2 was also an example of a pathogen that was kind of spread throughout, and we saw airborne spread from that as well. N95 mask is generally what's recommended, or is what's recommended for those pathogens in a healthcare setting. What I think SARS-CoV-2 helped to kind of fully emphasize is that really when you're speaking, talking, etc., you actually have a large group of droplets through airborne, and it kind of depends on where the virus is replicating for an individual patient, and a lot of other factors like ventilation, etc. And so that's kind of the reason that sometimes, there would be these stories of people living together and wouldn't actually get infected by SARS-CoV-2, and yet you'd have another story where one person went kind of before symptoms to a party with 15 people and half the people got it. It's just, there is variation there. What's important though in the healthcare setting is we want to not have any transmission of these pathogens to our healthcare workers and specifically to our other patients as well. And so we have to be very careful. And so with that, we kind of have definitions of things that require standard precaution is really just gloves if you're dealing with body fluids, so certainly with blood, but also even with suctioning and other things can sometimes come up. People don't always think about that being a potential place for splashing, like airway maintenance, but it's important to even wear gloves and sometimes goggles in that context. Contact precautions, those are the gowns. Of course, droplet is your routine surgical mask, airborne is your N95 mask, and so a reminder of some of those things. So cytomegalovirus comes up a lot, not something we've talked as much about today. It's more for certain immune compromised folks, but healthcare workers will sometimes ask questions about it because it's been associated with certain things in pregnancy, et cetera. Really, standard precautions is sufficient, much like HIV. Standard precautions is sufficient for that virus. Droplet precautions is a lot of the respiratory viruses we've discussed, influenza, rhinovirus, adenovirus, et cetera. For some of those are actually spread more fecal-oral or through surfaces, so that's why you actually need contact instead of droplet for things like RSV, metapneumovirus. They're just spread as fomites, so the secretions get on a table or something else and is passed that way. And then airborne SARS-CoV-2 is what you're most familiar with, but measles is also something that's spread through that route, and again, that's why you would put that patient in airborne isolation with the N95 mask. The reason those two are in red, adenovirus and SARS-CoV-2, is that they actually require contact as well because they can be spread through surfaces also. So, takeaway points, first things first, think about the syndrome. What are you diagnosing the patient with? What do you think the area of inflammation is? And is it localized or is it more diffuse? If it's more diffuse, it's just really just a common cold. If it's localized, they may require antibiotics. It kind of depends on the syndrome. For the common cold and others, they're not going to benefit. And so making sure you're first making the diagnosis and then choosing the therapies to most help. There are certain viruses that we do have antivirals for, specifically influenza and SARS-CoV-2. And so you want to recognize those and treat them when appropriate, particularly when you can catch it early and in patients that are at risk for severe disease. That's probably where the most benefit is going to be. There are, again, not many things that have objective benefit for common colds. It's a lot of things people can get over the counter, some things that anecdotally they feel work for them, but I think at least having some of the data on what by studies has been shown to have more benefit for patients can be helpful if you have a patient that's struggling and hasn't been able to find something that works. And that AAFP review article is a really nice place for that. And with these viruses, when we have several vaccines available. Probably the newest one that people are talking about is the RSV vaccine. In patients where that's appropriate, it's really helpful to get them vaccinated. It helps to prevent spread, both for the patient but also in the community. It is really, the other things here like hand hygiene. So really this is more for, and you may have some of these patients on your panel, when you're talking about severely immune compromised patients, some of them are still not back to living life fully normally, at least when the viruses are spreading to their community. They're worried about going to, a grandkid's school event or fill in the blank. And so I think for them, I try to reinforce both, vaccination of them and those around them when able, but also hand hygiene can help. Well, we mentioned several of these viruses are spread actually through contacts and fomites, so making sure you're being careful with washing your hands before touching your mouth, touching eyes, etc., really anywhere on your face. And then in certain contexts, I still have patients that will mask it. There is probably benefit to the patient or to the person wearing the mask if they're severely immune compromised, especially because ultimately it kind of gives them some freedom to be able to go into spaces they'd otherwise feel uncomfortable. So I talk to them about those who are concerned, what would be highest value, and generally that's like a KN95 mask, which is pretty easy to wear correctly. And probably has the most, at least like objective benefit as far as amount that it filters. Have less and less patients that are doing that at least routinely, but some that kind of do turn it on when that, when we're in the middle of an outbreak. With that, I think that's everything I have to discuss today. If you have any additional questions, you can follow the things there in the website to submit them. Thank you so much for letting me join you.